Good evening and warm welcome to the 21st lecture of Active Learning Session for Pediatric Orthopedics. As we mention all the time, the aim of these sessions is to connect our trainees, those trainees across India, to the world experts. I am Dhiren Ganjwala, a pediatric orthopedic surgeon practicing in Ahmedabad. The speaker for today's session is Dr. Shafique Pirani. Actually, Shafique Pirani is well known, and I think that he is a very prominent and the eminent person to spread the Ponseti technique in India. Shafique Pirani is a clinical professor at Department of Orthopedic Surgery at University of British Columbia. He is widely known for his contribution, the two contributions which I must mention. The first is the Clubfoot assessment tool, which is called the Pirani Clubfoot Severity Score. And the second one is a very unique study where he tried to look at what happens to the feet which undergo Ponseti treatment and a MRI study. So these are the two great contributions for us to understand the Ponseti technique. In addition to that, he has traveled across the globe to spread awareness of Ponseti method in developing nations. In last session, he covered diagnosis, classification, assessment, terminology related to clubfoot. And in this session, he will share his views on a very important and practical points, that is casting, tenotomy technique, bracing, follow-up, and how to detect early relapse. We are not going to cover relapse per se in the session because we have two sessions lined up in the future, in the coming future. Like last session, we expect that there will be many questions from our enthusiastic viewers. And so Dr. Shafique will answer all your questions in last 20 to 30 minutes. So whatever questions you have, please write them in the chat box and we will take all the questions after the lecture is over. I'm very happy to announce that the coming Friday, that is 21st of April, we have another interesting session and we have a star faculty, Professor Stuart Winstein. He will be speaking on a very important topic, that's surgical technique of close reduction, open reduction, and acetabular osteotomy for developmental dysplasia of the hip. So with that short introduction, now I hand over to Shafique for his lecture. Over to you, Shafique. And thank you very much for accepting our invitation and sharing your vast experience with us. Thank you.
Thank you, Dr. Ganjwala. I hope you can hear me okay.
Yes, yeah, perfect.
I'm just going to start my slide presentation. To start with, I want to say thank you so much for your very kind invitation for me to talk about something that is very dear to me, which is the fate of the child yet to be born with clubfoot on this planet. We have the ability to make things better for them, and Dr. Ponseti has shown us how. And our job is to do that. And I see, though many children are well corrected, the problem is not solved because many times things don't go quite right. And my focus is today to talk about what I believe is some of the important points, not only focusing on manipulation, casting, tenotomy, and bracing, and I know that the concept of relapse will be addressed later on. We talked last time about pathology, and to start the ball rolling, I just wanted to focus again on what Dr. Ponseti has described as the pathology, as this is what we need to correct. There is posterior medial retracting fibrosis, abnormal thickening and shortening of the capsular ligaments, tendon sheaths, and tendons posterior and medial to the ankle joints, gastrocsoleus contracture, posterior medial retracting fibrosis, and that causes secondary tarsal deformations and misalignments. And this is Dr. Ponseti's very famous dissection to show all the deformations and misalignments, and they're all numbered there and then enumerated. And then he wrote in 1996, after thinking about this, a well-conducted orthopedic treatment based on a sound understanding of functional anatomy. And that is basically the way the subtalar joint works the way that if you abduct it, it will evert and extend. And on the biological response of young connective tissue and bone to changes in direction of mechanical stimuli can gradually reduce or eliminate these deformities in most club feet. So what is this biological response? Can we see it? How do we understand this term biological response? And this is what I tried to investigate in my MRI studies from many years ago. And so here's a picture of a clubfoot before treatment and the MRI of the talus and the navicular, and it shows the deformities that Dr. Ponseti's dissection showed. And then what we do is at the end of treatment, we do the MRI again, and it shows that actually everything corrects. And so we have to be very confident that if we do this right, the technique right, then we can correct these deformities, not only the misalignments and the malformations, but also the contractures which are present that can be corrected by manipulation and casting. And then the bracing will be there to prevent their relapsing. And of course, I can also like to show you from the plantar aspect, week 1, the medially tilted distal calcaneal articular surface and the medially displaced cuboid. And as you correct the foot, and here you see the elements of the Pirani score improving, the curved lateral border as well as the medial crease, you can see that the cuboid is now realigned and the distal calcaneal surface becomes orthogonal to the long axis of the calcaneus. But I also wanted to show you these pictures because this is another study we did where we were able to do a serial MRIs on children with club feet. And then we were able to turn the 2D pictures into 3D pictures so we could show actually what was happening more clearly to the tarsal bones. And here you can see from the front aspect how from the anterior view, how the structure is correct, and also from the plantar aspect, how the structure is correct, and from the lateral side, how everything corrects. But actually, this is the important slide here, that when did the things change? And we were able to do an MRI before manipulating, and then immediately after manipulating the foot. What changes happened during the manipulation? And here you can see the blue, the blue and the yellow, the tenonavicular joint, and you can see that the changes happen during manipulation, and the manipulation therefore becomes extremely important. And the bottom pictures show actually the change in the shape of the navicular before and after manipulation. So the magic of the Ponseti method, we all focus on the casting, but the magic actually happens during the manipulation. This is where it's important to do the manipulation exactly right, because if you do it exactly wrong, then the changes in the shapes are going to be different. They're not going to be the shape changes that you want. And here's another series of pictures where we took MRIs A, B, and C. A was a few minutes after the manipulation, week 1, and then B is before we took the cast off a week later. And then C is when we took the cast off and then we took an MRI to show what happens. And there's not much change. And this tells us actually that there's very little that happens actually to the tarsal anlag and in the cast. What actually happens is that the tissues we don't see, which is the ligaments, et cetera, they become more supple, although exactly how that happens is unclear. In any case, so it leads to these series of diagrams. How does the Ponseti method actually correct the deformity? So here you see a diagrammatic, a cartoon representation of the deformed tenonavicular joint in the posterior medial contractures, as well as the tibialis posterior pulling on the navicular. And during the first manipulation, you can see with the thumb on the outside of the talar head that the purpose of the manipulation is to reduce the deformity as much as possible by pulling the navicular away from the medial malleolus, and then we apply the cast with the navicular, the talar navicular joint in the position of maximum correction, of obtainable without hurting the child. And so that's what our MRI showed. And when we remove the cast, you can see there's the red has gone to an orange, which is somewhat improved. The spring is a little stretched. And the important point here in red is that the cast must be effective, i.e., if you put on a loose cast, then it doesn't work. The cast has to hold the position of the foot in the maximum corrected position, because it's only then that the retracting fibrosis will lose tensile strength. And so if we carry on, then the second cast, we manipulate it and things improve further. And another cast, and then so there's sequential stretching of the retracting fibrosis, sequential improvement to the tarsal alignments and shapes, such that when we take the last cast off, the red talar navicular joint, which is deformed, is now turned into a nice green shape where there's a congruent shape, and the spring has been stretched out, and the deltoid ligament, etc., is much improved. So I wanted to just show this is kind of a hypothesis, a series of cartoons as to what we think actually happens, how the Ponseti method corrects the deformity. So what about this idea of effective manipulation and casting? Well, here's a baby, and the baby is, in this particular diagram, is breastfeeding. And the reason this is important is because if the child is comfortable and not fussing and not crying, then you will get an effective manipulation and cast. However, if the child is crying, then what happens is that the yellow arrow, which is a tibialis posterior, the baby's tibialis posterior is constantly firing, and you're struggling against that tibialis posterior and the calf muscles contracting to try and make things better. And the cast you can apply, it's not going to work so well. It might be a little loose. It'll be very hard for the cast to be applied in the position of maximum available correction. And then when you remove the cast, there's no improvement. So this is a concept that I want to raise, is that manipulation is really important. And the casting has to be done with the foot corrected maximally in maximally available correction. That's why the more experienced you are, the fewer the number of casts. And that's why if you're taking 8, 9, 10 casts, it may be that you're not putting on an effective cast when the time comes. And the problem is we have no way of telling if it's a both bones forearm fracture. You can take an X-ray and you can understand the position of the bones and decide if you want to put another cast on or not. But in the situation of a clubfoot, we don't have that ability to see what's going on inside the cast. So how do I do it? Well, I tend to sit. I like to sit. Everybody sits down, and it's always the manipulator, which is usually the surgeon, the assistant with plastering skills. Need two people to know what they're doing, and then the mother is there with the baby on mother's lap, not on the couch. I prefer to have the baby on the mother's lap, and if possible, have the mother either feeding from a bottle or breastfeeding. And in this situation, you'll see that on the right foot, the head is at the right breast, because then the right foot sticks out. And the surgeon is the one with the gray hair and the blue hands, and the assistant with plastering skills is he's younger, of course, so he's got black hair and he's got the gray hands. And so what is the sequence of correction? Well, we all know the first thing we need to do is to correct the cavus by elevating the first ray or supinating the foot. Supinate the foot is the first thing we have to do in the sequence of correction. And then what we have to do is to adduct the supinated foot, to abduct the talus under the calcaneus. And when we abduct the talus under the calcaneus, from what we understand about the functional anatomy of the subtalar joint, as we abduct the talus, the subtalar joint will pronate automatically and correct varus and some of the equinus simultaneously. So The trick is, sequence of correction is supinate the foot and then abduct the forefoot under the talus, abduct the forefoot to abduct the calcaneus from under the talus. And as you abduct the calcaneus, it's going to evert and extend simultaneously, and we'll get automatic correction of those components. So, what's the technique? Well, you have to hold the foot. Now, this is the right foot. The surgeon's left hand, the manipulator's left hand, the thumb finds the talar head, which is just 1.5 centimeters directly anterior to the tip of the fibula in most cases. The index finger and the middle finger rest on the medial side in most cases, and then the right hand holds the forefoot. The thumb is on the dorsal aspect of the first, second web space. The index finger is on the medial side of the first ray, and the long finger is underneath the first ray. That's the position that I suggest to everybody as to how to hold the foot. That's an important thing to teach and to understand. Now, how do you supinate the foot? Your long finger, which is underneath the first ray, elevates the first ray, whilst the thumb, which is the pink arrow, provides counter pressure on the head of the talus to correct the cavus and supinate the foot. And then the abduction of the forefoot is where the index finger, which is on the medial side of the first ray, abducts the forefoot with counter pressure on the left thumb on the head of the talus. And then you hold the foot in that position whilst the first cast is applied. So here's a video of the manipulating technique. So here's my long finger supinating the foot with counter pressure on the head of the talus. The thumb, the left thumb, is on the head of the talus. Now the index finger here comes on the medial side, and the thumb comes down on the top. Now I'm holding the foot like I showed you in the picture. And now I'm abducting the supinated foot. And in your mind's eye, you will be able to see that posteromedial retracting fibrosis stretch. And that's as far as I can take it. Now, this baby is not under an anesthetic. This baby is on the mother's lap feeding. And I'm just trying to show you this very, very clearly how, and that's where the magic happens. That is in that situation, right? There is where everything changed. Now, another way is you can have the index finger behind the fibula, like that. The tip of the thumb is finding the tip of the fibula and moving. Let's see if I can show you that again. Another way, the index finger behind the fibula, the thumb finding the head of the talus, and then the same maneuver with the 3 fingers in the forefoot. That's abducting the supinated forefoot. Okay, so now you've got the foot abducted, and you don't have, I don't think you have to do this for 5 minutes. You just do it once, you establish in your own mind how much correction you can achieve without hurting the child. And now your job is to put on an effective cast. Well, you've got to get your hands out the way, because if you don't get your hands out the way, then how's the cast going to go on? So how do you get your hands out the way? Well, this is where the hands were when you finish the manipulation. So I'm just trying to show you, and I have a little movie also, but the way I get my hands out the way is I have to get my left hand, the thumb of my left hand, away from the head of the talus. So it goes light blue, and in the purple, A to B. My thumb, left hand thumb, goes from A to B, but before then, my dark blue thumb, the forefoot, the thumb goes from A to B to maintain some counter pressure on the head of the talus. And once my left hand is up and the thumb is on the outside of the knee and pushing against the lateral aspect of the proximal leg, my right thumb can move back to where it needs to be, whilst the index finger is providing counter pressure. That's how I get my hands out the way. And maybe I can show you in the little movie how that happens too. So here you see, I've manipulated the foot. My right thumb finds the head of the talus. My left hand moves out the way, gets it in the position. And now my hands are out the way. And I'm now holding the foot in the position of maximum available correction to see how we can start applying the cast. Now, whilst the surgeon is holding the correction, the assistant applies the padding and the cast. And you can see in this cartoon that the gray on the left-hand side is the soft roll or the padding, and there's only two rolls over the foot. And in fact, you can see the fingers are inside the padding, not outside. The two rolls over the foot, and as you go up to the leg, then three rolls. Then you do just the below knee at the part. You don't do above knee. And then the plaster, there's 2-inch plaster of Paris, well soaked, 4 rolls over the tips of the toes, including the surgeon's fingers, 4 rolls, and then as you go up, you overlap by 3/4. So you get 3 to 4 layers all the way up to the knee, and then you mold everything together for strength. And I'm going to show you that. So here we go. The foot is being held by the surgeon, and the assistant is 2 rolls of padding, and then overlapping by 50% over the foot, not too much, otherwise the cast will slip, and then 3 rolls overlapping by 3/4 until you get to the knee. And once you get to the knee, you stop, and then you apply the cast. Now, applying the cast, you can see the foot is still being held, and the fingers are inside. Here's a well-soaked roll of 2-inch plaster of Paris. 1, 2, 3, and 4 rolls around the toes, and then overlap by 3/4. And you can see how, because it's so well soaked, that the plaster of Paris is actually intermingling between the layers. Old technique, very important. Otherwise, you don't have good strength. Don't make the plaster of Paris too dry. It's a little knob there to make it easier for removal when the time comes. And so now the next part is I've shown you this already. Oh, now you have to mold. Yeah, the purpose of the molding is to take away dead space. And the places that I think dead space exists mainly are anterior to the ankle, underneath the first ray, and behind the Achilles tendon. So how do you take those dead spaces away? You have to mold over those places. So it's the left thumb that actually pushes up here underneath the first ray to eliminate that dead space. And then the index finger of the left hand, it moves up and down. This thumb can stay where it needs to stay because there's padding there, so you don't need to move it too much. But this index finger needs to move up and down because you don't want to leave a dent on the anterolateral aspect of the tail head. And very often we see pressure sores in that area. And then the right hand index finger, it molds above the heel prominence, not over the heel itself, to take away that dead space. This is what's going to stop your cast from slipping with this molding. And you can see we haven't touched the heel at all. The heel actually sits very nicely in the little cup that's made for it by this molding fingers. So can I show you that? Okay, so here we have a little video. And what I'm doing here is now the surgeon is taking over, okay, from the person who's holding the foot and starting to do the molding. And here you see I'm molding all the layers together. Oh, and here my index finger of my right hand is molding above the heel. The thumb here is pushing up to take away that dead space. And here you see it's now dry. There's the knob. There's no pressure sore here at all, no dent. And if I show you the under aspect, you can see here the the foot is supinated and abducted, the cavus is corrected, and there's a nice mold above the all right, this video is a little fast. I can show you again. There, the cavus is corrected, and then you can also see the heel the heel prominence is there, but there's a mold above the heel to stop the calcaneus from slipping up. That's the Bijlani part. So it's a two-part cast. Second part is put on, and it needs to go very high. I like to put a little slab on the anterior aspect of the knee to stop, to make it not too thick. And then we trim away to show the toes and leave for plenty of space. And this is a cast, excuse me. This technique of manipulating and casting is exactly the same. The only difference is that the position of the foot changes with a sequential casting. That's how you move from cast 2 to cast 3 to cast 4. The position of the hands and the technique is the same. Once you get correction, sufficient correction, or you think you got sufficient correction, cavus adductus varus will be much improved, or if not, and it needs to be fully corrected before you move on to correcting the equinus. And half of the equinus, which comes from the subtalar joint, will be gone by the time the subtalar joint is fully corrected, and the remaining equinus is corrected when you do the tenotomy. So what is the indication? When are you supposed to do the tenotomy? Okay, so earlier on, you're doing these casts to improve the position, and then you want to do the tenotomy at a certain point. And this is where the Pirani score helps. Please excuse this red dot. I'm not sure where that comes from, but this is the Pirani score. This is why it helps, because earlier on, when the hindfoot, when the midfoot score is high, you still have to do casting. You cast until the midfoot score is less than 1. There you go. The hindfoot score still needs to be high, greater than 0.5. Tailor head sign needs to be 0, and abduction needs to be greater than 60 degrees. And that's the indication to perform the tenotomy. Tenotomy performed any earlier will not be effective, because the calcaneus will still, to some extent, be under the talus, and you won't get a full correction. So how do we prepare? We counsel the parents. We explain it's a safe outpatient procedure. It's done before the last cast under local anesthetic. You don't need a general anesthetic. In fact, general anesthetic is dangerous in these babies. The supplies, very, very simple. Everything is usually available. I like to use an insulin syringe or a TB syringe with a 25 gauge needle for my local anesthetic. It's just a simple 1% lidocaine. Any kind of blade that's available, 15 blades are universally available, a little bit of prep solution, and some gauze. And that's all you basically need. And the positioning, I like to do the tenotomy with an assistant holding the leg. A parent can be in the room if they want to be. If you're comfortable with that, they can comfort the child. The foot is positioned right at the end of the bed, here we're going to show the right foot. The key anatomy, to be important, the importance of the key anatomy, you need to be very aware of the posterior tibial neurovascular bundle and stay away from it. The sural nerve, and stay away from that. And the Achilles tendon. And important thing about the Achilles tendon is that it broadens as you come distally. So if you want to have an easy cut of the Achilles tendon, go proximal. Go at least 1 centimeter, if not 1.5 centimeters away from the calcaneal tuberosity. You palpate the tendon. So here's the gray hands of the assistant stabilizing the foot, the blue hand of the surgeon palpating the tendon. And if you can palpate the tendon, then you know where it's easiest to palpate. That's where you want to try and cut it. 1.5 centimeters above the calcaneal tuberosity. The assistant's left hand stabilizes the knee, the right hand stabilizes the foot, dorsiflexes the ankle, tensions the Achilles tendon, and externally rotates the leg to improve the surgeon's access. The surgeon palpates the tendon and then inserts local anesthetic just medial to the tendon, and just a little bit, maybe just a quarter of a cc. Any more than that, and you'll be making the tendon less easy to palpate. Surgeon then inserts the blade parallel to the tendon from a medial side, staying away from the neurovascular bundle. You can see, aiming for that fat space right there. Then you turn the blade 90 degrees to make the sharp side towards the tendon. And as you approach the tendon with the blade, you'll experience a pop where there is the tendon is transected and there's a sudden increase in dorsiflexion. And here's a little video to show it. And so this is the prep solution. And the surgeon holding, and the assistant holding the foot and showing that dorsiflexion is limited. You can see the posterior crease sign there. Here's the surgeon palpating the tendon, making a little mark to make it easy for themselves, making sure that they go 1.5 centimeters above the calcaneal tuberosity, a little bit of local anesthetic. And then they wait a little bit. Again, everything is stabilized. Here's a 15 blade, and you can see very quickly that's done. All right, and you might not have seen the sudden ankle extension there. It happened, but what you'll see now is the result of the tenotomy. There's sudden ankle extension and dorsiflexion greater than 15 degrees, and that's a very nicely performed tenotomy under local anesthetic. And then we apply the cast. The post-tenotomy cast, it needs to go in the position of maximum available correction. You can see the Achilles tendon is nicely tenotomized there. If you have sufficient ankle dorsiflexion, which is usually possible, more than 15 degrees in young infants, the cast is on for 3 weeks. And in that 3 weeks, the tendon heals in the new lengthened position, and you have a corrected foot. In older children, dorsiflexion may be limited. You only might get 10 degrees. So in that case, you need to apply a cast for a week and then come back and put on the cast. Keep changing the cast every week until you get maximum available dorsiflexion. So about bracing now. Not going to say too much about bracing, but what I am going to point out is this PhD study by Andy DeMeo, a biomodeling investigation of bracing of clubfoot children treated by the Ponseti method. And what he did is he investigated by doing this surrogate biomodel what happens with different types of braces to all these muscles. And he looked at all these different muscles and all these different bones. And of course, it's a PhD, so there's a lot of information there. But in the standard of care brace, which is the foot abduction brace, and here we see the Ponseti brace from Iowa, when you use this brace on the biomodel, you can see this is the change in muscle tendon tension after applying the standard of care brace. You can see all these muscles, the tib post, the soleus, the lateral gastroc, medial gastroc, there's an increase in muscle tendon tension. That's why this brace is so important, because it maintains the stretch in those contracted ligaments, the posterior medial rotator fibrosis, which has been corrected by the casting. If we don't do this, the posterior medial rotator fibrosis will come back because we haven't fixed the posterior medial rotator fibrosis. We have to wait for it to go away over time. Now, why am I showing you this particular picture? Is because people say, well, this brace is too hard. I'm going to put on an AFO. Well, what happens when you put on an AFO? Right? That you don't get the same stretch. And I'll show you the difference. So the AFO, it does some stretch, but in particular, it doesn't do anything to the tib post. Then some people will say, well, we're going to put on this articulating brace because the children are happier. Well, Andy DeMayo's PhD says it does even less because everything moves. So I wanted to show you that so that you would understand that the standard of care bracing needs to be this difficult, unfortunately difficult brace that holds the foot in this position. Dr. Ponseti worked this out 30 years ago, and we're still having to learn the message over and over again. And this is why this brace is so important, to maintain the stretch and to hopefully prevent the problem of relapse. The longer this brace is worn every day, and I don't know exactly how many hours, but at least a certain number of hours every day, the longer, the less likelihood it is that the clubfoot relapse. Well, I've taken 33 minutes. I think I'm going to stop and answer any questions. Kiran?
Yeah, thank you, Shafique. We have two questions. The first question is by Dr. Jitendra Jain, and
Yes.
a very common question all the time in conferences, it's asked, in what percentage of cases do we need tenotomy? Because parents are very reluctant for tenotomy because they consider it as a surgery and they are not very keen. And that's why many times we have to answer that question, or we need to understand that are we doing it too much or are we doing too less? So in your opinion, in what percentage of cases we need tenotomy?
If we believe this indication for tenotomy, that the midfoot is corrected, but the hindfoot is not corrected, right? And then the tenotomy is usually indicated in about 90%. Okay, and so using the Pirani score, it's easy to demonstrate. In fact, what I do is I show the parents. I say, look, feel the tendon; it's tight. Do you want me to release it? And they'll say yes. And that's the point here. But if in 10% of cases, approximately, the hindfoot correction happens at the same time as the midfoot correction. And in that situation, if this line is going down like this, then there is no need for the tenotomy. So that's the way I tell. And in fact, if you go back to read Dr. Ponseti's book, Dr. Ponseti's book says, and he wrote that you can do full correction without the tenotomy. It just takes 3-4 extra more casts, but you have to be very careful because by dorsiflexing the foot on the tibia, you can crush the dome of the talus if you're using too much force. So it has to be very slow. So in his book, he says you can facilitate the earlier correction of equinus by doing the tenotomy. And so in his cases, and I believe it's a majority of cases, 90% is approximately what you should be looking for. If you've got a tenotomy rate of about 50%, you could still correct, but your number of casts will go up higher. And I suspect you'll be putting the child's dome of the talus at risk because you can imagine how soft that cartilage is. As you dorsiflex the foot, you've seen from the MRIs how shape changes, and you can create a flat top talus. So the answer to the question is, I think about 9 out of 10 children with my talk today has been about the idiopathic clubfoot, the usual clubfoot, not about syndromic club feet or other types of club feet. Those are about a little more complicated. I was just trying to go over basic principles, but in the usual idiopathic clubfoot, the 90% of all the club feet we see, about 9 out of 10 of those will benefit from a percutaneous tenotomy. And I've shown you the blade is inside the skin for just a few seconds. And the whole procedure, if you do it in the clinic, is very fast. It doesn't need the general anesthetic. In fact, I'd highly advise against general anesthetic because you're making the procedure much longer. Okay.
Yeah, then there is a question. In our country, it is difficult to give plaster when the mother is breastfeeding. Mothers are scared. So what is the option? Can we do it with the Phenargan? I would suggest that now we have a full set available, midazolam available as a spray. So we can use midazolam spray, which will have a very quick action. But yes, Shafique, what is your take on that?
So I had an interesting experience. I was in Pakistan a decade ago, and Bangladesh. These are Muslim countries. And, if I ask the doctors say, oh, no, the parents will never agree. And I asked the mother in front of the doctors. They said, do you want to breastfeed? And they say yes. So if the parent says yes and the doctor says no, listen to the parent. And especially, there is more and more acceptance of breastfeeding in different contexts. And of course, I have to be very sensitive to the culture of the country. I don't want to create problems, but my thing is fine. If it's not the breast, then bottle feed. Have the mother bottle feed, but having somebody hold the child on their lap, right? If it's a parent, that in itself is very reassuring for the child. If you put the child on a bench, it's a foreign situation. But that's just my impression. The proof of the pudding is how can we make it so that you get to be able to have a child that is allowing you to do this kind of casting without fussing, and so I go back to this. What we want to do is to avoid that baby, right, crying like that, because if they're crying like that and are moving their legs, then the surgeon who's stronger than the baby will use all their strength. You want to use gentle pressure. But Darren, please tell us what you do, and there's always options to learn from different situations.
Yeah, we have a midazolam spray available, and midazolam nasal spray works wonderfully well. And like say in less than 10 minutes, it makes the child sedated. And like definitely we can give plaster without much fuss. So Phenargan is a long-acting medicine, while on the other end, midazolam is a short-acting medicine. Midazolam is something full set, which the anesthetists use it very routinely. So either in the spray form, we can use it.
Excellent. If you have this, I have no experience with that particular spray. But if the safety profile is satisfactory, and if there's any kind of risk and that's being managed, can be managed safely by the person who's administrating it, why not? It's up to it's a discussion, really. I mean, the parent needs to make that choice. I'll take your advice. Whatever you think is okay in your country.
Yeah, so that is one option. If breastfeeding is not acceptable to parents or to the family or to the doctor. So that is one option.
Exactly.
Yeah. Then there is a question. In a unilateral clubfoot case, still we need to put a foot abduction brace in 70 degree.
Okay, yes. So let's go back to this slide here. Andy DeMayo's PhD thesis was excellent because it gives you exactly why you need to put that brace on. So Andy DeMayo looked at all of these muscles, right, and bones in his PhD thesis and figured out what happened to them all when you put on this brace. Okay. And he found that if, and I don't have the graph here, but if you didn't put it in the proper position, then you didn't get, so, okay, in the unilateral, let me rephrase. In this brace, the normal foot needs to go in at 30 degrees. Only the club foot needs to go in at 70 degrees. So if you're asking me about the braces you have available, which I think may be 70 degrees on both sides, that is maybe a bit extreme, I think, for a normal foot. In fact, I've tried to have that discussion with the brace designer that there should be made for unilateral braces, for unilateral club feet, the foot, the normal foot needs only to go in at 30 degrees. And indeed, when I was doing my work in Bangladesh, I would actually advise the doctors in Bangladesh and also in Uganda, where this brace was originally designed, that actually in the unilateral case, because the bar is only 6 millimeters cold iron, it's malleable, it's bendable. So you can actually put the bar over your knee. The doctor can do that and reduce the 70-degree abduction to 30 degrees. Is that the question you're asking me?
Yeah, exactly. So that was a question. Yeah. So you're given a very clear-cut answer that if it's a unilateral, we need to keep the normal foot into 30 degree. Then there is a question from Noor Wahab, who is an orthopedic resident in Pakistan. His question is, in first two casting, when we treat cavers by elevating the first ray, automatically the foot supinates. So is it equivalent to exacerbating the deformity in the first two casting?
So let's go back and look at the pathology. So the answer to that question depends on an clear understanding of the pathology. And I want to go back to Dr. Ponseti's diagram. Sorry, this one. Okay. So here, what I want to show you is that the forefoot is actually pronated with respect to the hindfoot. That's the first metatarsal here, and the medial side is plantar flex with respect to the talus. So you have to supinate the forefoot. You have to elevate the front of the foot to bring it in line with the hindfoot. And that isn't exaggerating the deformity. It's actually correct. It's unraveling this part of the deformity before you unravel this part of the deformity. And it's been a common, it's a very common misunderstanding that supinating the forefoot is aggravating the deformity. And indeed, when we go back and look at some of the teachings by others, they advocated pronating the forefoot as part of the treatment, because that's what seemed to be the appropriate thing to do. So the answer to the question is, are we aggravating the deformity by supinating the forefoot? No, you're actually correcting the deformity by supinating the forefoot, because you're bringing the front of the foot in line with the back of the foot.
There is a question. Yeah, I think that's very clear. That's very clear. Yeah, there is a question from Devendra, and Devendra, he's pediatric orthopedic fellows at Kasturba Medical College, and his question is, what about a Bijlani cast in those children who came late after the walking age? So can we consider, instead of above knee plaster, a Bijlani plaster?
So what's the purpose of the above knee cast? The purpose of the above knee cast is to hold the deformity corrected. Okay, so then you must have a technique. If we are stretching these ligaments on this side to get the foot from this position to this position, how is a below knee cast, which is circular in this area, going to prevent that foot from rotating? So Dr. Ponseti indeed let's see if I can show you. Dr. Ponseti tried below knee casts, and he found it didn't work. And the reason was because it was very hard to hold the this tension to make the cast effective. Because if we don't put the above knee cast on to provide counter pressure, which simulating this thumb here, if we don't do that, then all of this is going to relax. So I think that below knee casts, if you have a way to stop the leg from rotating, it might be possible. But generally speaking, I don't know anybody who's actually discovered a technique of making it happen that way.
Okay, thank you. Then there is a very difficult question from Dr. Anil Agrawal from New Delhi. How to correct mid-foot break in an inadvertent case foot is pushed without tenotomy? So you mentioned about one of the complication is flat top talus, which we can't see outwards, but the midfoot break is one thing which we can see if we look at carefully, if the tenotomy is not done. So in your experience, how do you treat this complication?
Well, of course, you prevent it, which is the first line. And the important part is in preventing midfoot break is to avoid dorsiflexing the foot until the calcaneus is out from underneath the talus, lateral, and then doing a percutaneous Achilles tenotomy to stop that from becoming a deforming force. But supposing it happens anyway, in my own experience, and this was after discussion with Fred Dietz. Fred Dietz, he was Dr. Ponseti's right-hand man. He had a philosophy that if you're starting to go wrong in the treatment of a clubfoot and you're creating a new deformity, leave things alone, go away for 4 weeks, and let the clubfoot become a clubfoot again. And once it's become a clubfoot again, you start treating it as a clubfoot. So in the case of a complex clubfoot, before Dr. Ponseti came up with the modified technique of casting, Dr. Dietz's idea was you leave it alone, let it become a clubfoot again, because the problem is the human being has come and created a new deformity. So in the case of a rocker bottom deformity, and I haven't seen a large number, but the number I've seen, you leave it alone. You tell the parent, and Anil, I can show you some slides at some time to show you examples of this, but you leave it alone, you don't touch it, you let it become a clubfoot again, which it will. It'll go back into cavus adductus varus and equinus because all those forces of retracting fibrosis will take away the rocker bottom deformity and make it again into a clubfoot, and then you start treating it again. And I've been very successful in doing that.
Okay, then there is a question from Arul, that's from CMC Vellore. For assessing the ankle dorsiflexion, which you mentioned in your lecture, do we need to assess with the foot in inversion or in neutral position? Because this is a question time and again when we are suggesting to assess the ankle dorsiflexion in the cerebral palsy patient, we say that we need to invert the foot, lock the subtalar joint, and then we need to carry out dorsiflexion at the ankle. So does that apply in clubfoot?
The clubfoot, the subtalar joint in clubfoot is different from the subtalar joint in cerebral palsy in most situations. Because in cerebral palsy, most of the time, the subtalar joint is mobile, whereas in clubfoot, you have to be correcting the subtalar joint at the same time as you're correcting, well, during the same process, I should say. So you may not have the opportunity to evert the subtalar joint in your measuring of ankle dorsiflexion. So my own idea is I try and estimate the amount. I do the Ponseti maneuver I supinate the foot, I abduct the foot with counter pressure on the head of the talus, and then I look at the amount, I look at the lateral border of the leg and the lateral border of the hind foot, and I look and I see where am I? Am I still in plantar flexion? If so, how many degrees of plantar flexion? So it's different. And I think what you need to do is you need to have a consistent way in which you do this. There's no standardized way. That's one of the things we're working on right now, to figure out a standardized way of measuring passive ankle dorsal flexion in the clubfoot. But do it a standardized way in your own way, so you always do the same thing. And in the clinic, my recommendation would be look at the foot from the lateral side, do the Ponseti maneuver, get the foot out as far as you can take it, and then measure the ankle dorsal flexion. Because what you eventually want is the subtalar joint fully corrected and the ankle joint fully corrected. And you until you've got the foot out from under the talus, the amount of equinus is always going to be a combination of both ankle joint and subtalar joint.
Then there is a question, again, a very practical question. After, when it's a second or third cast, after attaining what degree of forefoot abduction do you suggest starting the correction of equinus?
So correction of equinus should only happen if you want to avoid problems. Don't focus on the equinus until you are sure cavus, adductus, and varus are corrected. So how are you going to be sure cavus, adductus, and varus are corrected? Well, you're going to use measurements of Pirani score, as well as the angle. And I'm going to take you to this graph again. There, okay. So you want to do these casts, until the midfoot is corrected. And one of the nice things about the Pirani score is it divides the clubfoot into a hindfoot and midfoot. So you want to have a midfoot score of less than 1. In other words, if you have a medial crease of 0.5, that's okay. If you have a curved lateral border of 0.5, that's okay. But you can't have a curved lateral border of 0.5 and a medial crease of 0.5. And you can't have a talar head sign of 0.5. The talar head sign has to be 0. That means the navicular is fully corrected over the head of the talus. So you need a hindfoot score which is high enough to warrant an Achilles tenotomy. You need a midfoot score of less than 1, i.e. midfoot score of 0.5 or 0, to ensure that the midfoot is fully corrected. The talar head needs to be 0, and abduction needs to be 60 degrees according to the Ponseti International Association. So this is when I think it's safe to proceed with correction of equinus, and do not proceed with correction of equinus until you reach this point. There's no point, okay? Because if you're correcting equinus all the time, you're simply putting a force on the dome of the talus and increasing risk for deformation there.
Okay. Then there is a question about needle tenotomy. I'm not sure whether you are aware about the tenotomy by using a sharp needle. 18 or
I've
20.
read the papers.
Yeah.
I've never done it.
Can you tell your views about that?
I've never done it. I think they say use an 18 gauge needle, if I remember correctly. Yeah. So the size difference between an 18 gauge needle and a 15 blade with a stab incision, especially a beaver blade, if you have access to it, or cataract blade, is not that big. The difference I see between the 18 gauge needle and a blade is a blade has an edge to it that's designed to cut. An 18 gauge needle has a sharp edge which is curved, which is designed to penetrate. So I've never used it. I've never had the opportunity to use it. I think those people who've had an opportunity to use it and are advocating for it need to describe exactly what the benefits are and how to use it properly. I mean, it's a sharp edge, you know. If it works in your hands, it works in your hands. But I've never used it. I don't understand why it's a problem to use a regular blade. The video I showed you, and I'll show you again, the blade is in. The blade is in for literally a couple of seconds. If we do it, if you're, let's just take it there. Just see how long this doctor takes. Blade is in, turn, done, out. Okay. So if you can do something that quick with an 18 gauge needle, that's great. But you need to have a very clear explanation as to why, what part of the needle is doing what.
Okay. Then there are two questions related to neglected feet, and we will take both questions together. The first is, in neglected cases, if there is a severe cavus is present, can we consider doing a plantar fascia release by needle or by knife before starting the plaster? That is the first question. And the second question is about, in a neglected case, do we need to carry out tenotomy or do we need to do lengthening, tendo-Achilles lengthening? I would reframe the question and ask you, up to what age do you carry out tenotomy?
Thank you, Dhiren. So thank you for the question. I'm going to request that we avoid using the word neglected clubfoot because although it's true that the foot wasn't attended to at the proper time, it gives a sentiment to the foot that somebody did neglect, and we don't want to actually advocate for that. It doesn't really point to the pathology, so I would tend to use the word untreated clubfoot. And we divide, the Ponseti International Association divides untreated club feet, idiopathic club feet, into those that were initially diagnosed in infancy, which means before they started to walk. And the reason why we do that is because there is no further deforming forces on that foot. That's just what the child was born with. And then there's untreated clubfoot, in which are diagnosed once the child has started to walk, and sometimes they've been walking for many years. And the difference, the pathology there of posterior retracting fibrosis is aggravated by the forces of weight bearing. So that was the first point. The second point is what to do about the cavus. You know, I have to actually come back to you, Dhiren, or your colleagues in India, because you have much more experience in the management of untreated club feet and walking child than we do in North America. My suspicion is that it will correct, providing the cavus will correct, providing the technique is performed properly. Because the collagen I don't know this for sure, but whatever the contracted posterior medial retracting fibrosis is, the collagen, it's the pathology in the arch of the foot is the same as the pathology of the collagen, or possibly posterior medial to the ankle joint. But if you have a series of cases where a study was done and say 3 or 4 casts were applied and cavus didn't correct, then of course one could make a very strong argument. So what to do for the recalcitrant cavus in the face of properly applied casts in the child that's been walking with an untreated clubfoot is a question that remains to be answered. And I suspect some of the factors may depend on how long that child has been walking, because if the child has been walking for long enough, then it might not simply be that the soft tissues are a problem. It may be that the bony tissues have become a problem. And the older the child, you might have a bony deformity present, particularly if they've been walking for many years. the answer to the question of when do you do lengthening of the Achilles tendon versus a tenotomy, that answer has changed. In Dr. Ponseti's earlier writings, he said you should do a percutaneous Achilles tenotomy under 1 year of age and open tender Achilles lengthening above 1 year of age. But he qualified that by saying that he didn't see those many cases of children above 1 year of age in Iowa. And then with experience from a lot of experience coming from different parts of the world, including colleagues in India, in his second edition book published in 2008, he wrote, actually, there's no need to do an open tender Achilles lengthening under 5 years of age, only above 5 years of age. But that's because I think there must have been a paper at that time that he had read, or he was informed by colleagues that tenotomy was perfectly satisfactory under 5 years of age. Although you might be faced with that problem, which I showed you, that you might need to do you might not get sufficient ankle dorsiflexion, and you might need to do sequential casting every few weeks, every week or so, till you get sufficient dorsiflexion in the older age group. But then I've been hearing from other colleagues in India who've been doing tenotomies even up to teenage years. So the answer to that question, when do you do Achilles tenotomy, or when do you have to do open lengthening, that's still an answer that needs to be explored. The latest writings by Dr. Ponseti, those are 15 years ago, is up to 5 years of age, but it may be that the answer can become forth more readily from your colleagues in India who've been doing this and hopefully publishing on it in older groups.
Yes, Shafique, we have already overshoot the time, but still we will take two questions, the last two questions. Okay. The first question is by Dr. Lokesh. And the question is that in many patients during the follow-up x-rays, we see a flat top talus and a wedge-shaped navicular. So what is the significance of that?
Unknown. Dr. Ponseti did look at x-rays in his follow-up cases, not all, just some. And he made a comment that the x-rays won't be normal. You can never get a normal x-ray after a clubfoot. It's rare, very rare. There are some deformities of the bones which are acceptable. The main thing is how are the joints, because in his view, the shape of the bone didn't really matter so long as the joint was supple, as long as the foot was supple and mobile, because the long-term longevity of foot function and freedom from pain depends more on the absence of stiffness and the presence of mobility and strength. This is what actually is the downside of doing joint invasive surgery, because joint invasive surgeries, like a posterior medial release, it can correct the shape of the foot, but it leaves the foot stiff and it leaves it weak, and therefore it doesn't last for a long period of time. So the wedge-shaped navicular, I don't think has any long-term problems as long as the talonavicular joint, the subtalar joint are mobile. The flat top talus, that's more of a concern because we don't know what the long-term prognosis is if you have insufficient dome of the talus in your 30s, 40s, and 50s. Are you setting yourself up for osteoarthritis of the ankle? And there's some interesting thing there that people do ankle replacements rather than ankle fusions. Well, why do an ankle replacement? Well, it's to replace the ankle joint motion rather than the fusion. The fusion is a successful operation, but people like ankle replacements because they like movement. So there must be some something about having some ankle joint motion, and ankle joint motion will necessarily be reduced if you have a flat top talus. So the question of the flat top talus remains open, the long-term natural history. And it's something that needs to be looked at. The subtalar joint, I think, has been solved in clubfoot, but the ankle joint hasn't.
Okay, the next question is also related with the same thing. And the question is like many children after clubfoot treatment with Ponseti are not able to squat normally. And answer to that, Shinam's question is very simple. Again, as Dr. Pirani said, that for squatting, we need 20 degrees of dorsiflexion. And in many patients, we don't have that much dorsiflexion after the treatment. And because of that, they are not able to squat normally. So I think that is what the reason. Dr. Pirani, would you like to add anything on that, my comment, or is it the reason?
Yes. You know, the North Americans don't put the value on squatting too much because they don't squat, right? So we have not approached this or looked at this question. How much ankle dorsiflexion? I don't actually know how much dorsiflexion of the ankle is required in squatting. And squatting is an important cultural issue in low middle income countries. And so it is the club foot in squatting. I mean, it's a very interesting topic. I don't know much about it. I would like to know exactly how much dorsiflexion is required in squatting. How important is, if the squatting is something that needs to be done daily, you know, then it's an important activity, and therefore it may be that there needs to be some more attention paid into exactly how much dorsiflexion is required during squatting, and how do we obtain and maintain the required amount of dorsiflexion during treatment in those cultures that squat. How do we obtain and maintain satisfactory ankle dorsiflexion so that the children in those cultures can grow up and participate normally in activities? And you know, we the example that comes to mind is that the knee replacements are different for different geographies. In some cultures where knee flexion is very important, the knee replacement design has changed, such as in Japan, to promote more ankle dorsiflexion, more knee flexion to accommodate for that cultural sensitivity. So the question is an important question about squatting. The clubfoot and squatting, I don't know if I've read anything on it. I'd love to read something about it to see, and then to figure out what is it that we need to do to obtain and maintain satisfactory ankle dorsiflexion to permit freedom of squatting as part of the function.
Thank you, Shafique. I know that you have our next meeting 5 minutes after the session. So thank you once again for sharing your views and making the things very simple. Looking at your picture, it seems that Ponseti technique is very easy. And I'm sure that everyone must have learned something or the other important message from your talk. So thank you very much once again for sharing your experience and vast knowledge with us. Thank you. Bye-bye.
It's my pleasure, Dhiren, and say hello to all my friends in India and hope to see you soon. Thank you so much.
Yeah, bye.
All right. Bye-bye.